It's going to be something of a continuation of what we talked in the last class. It's about prevention of intraoperative awareness. We talked a little bit last time about awareness, no? About what should be the inhalational agent's depth if you have to do that. Now, let us concentrate a little more on that awareness, what it is, and why we should be preventing it. On those lines, we'll have something. What is definition of awareness? Are you aware of what's happening now? Yeah? Or how do you define what is awareness? So the ability of a person, take off the patient, to recall any event occurring during the intended anesthesia. You take off that anesthesia with or without prompting. Awareness, if you want to design, you just take off that patient and take off that anesthesia from there. That is what is awareness. You are aware of the surroundings and you are able to recall it with or without prompting about it. That is, if it happens under anesthesia, then you call it awareness under anesthesia. That is the ability to recall with or without prompting whatever event that occurred during that period. Now, that's, if you look at the state of mind, you have different states of mind. One is consciousness. What is consciousness? There are so many other definitions of consciousness religiously and on other things, but let us confine it to our anesthesia and related things. It's a state in which the patient is able to process information from his or her surroundings. That is a consciousness. You are able to process the information from the surroundings. So I am talking, you are able to hear, you are able to process it in your mind and then get a meaning for that thing. So that is the state of consciousness. What is wakefulness under anesthesia? Has been used to describe patients who are able to react meaningfully to a stimulus during general anesthesia. They are able to react meaningfully under general anesthesia, but are not able to recall either the stimuli or the reaction post-operatively. Understand? I am able to react to whatever it is under anesthesia, but I am not able to recall it after I recover from that state. That is called wakefulness under anesthesia. Now, what is types of memory that we have? We have something called explicit memory and something called implicit memory. What is that explicit? Explicit refers to conscious recollection of previous experiences. If I just ask you what happened in the last class. Okay, you are able to recollect what happened in the last class? You came for the class? No. So you are able to recollect that I did not come for the class, so I do not know anything. So that is an explicit recall of whatever happened. But its implicit unconscious memory refers to changes in performance or behavior that are produced by previous experiences but without any conscious recollection of these experiences. That is, you are sleeping, something happens, it gets recorded. It is not that it is not, it's not recorded. But once you wake up, but you cannot recollect it. But the impression of whatever happened in your surrounding is impregnated in your brain all the time. So if I have to give an example for this, there's a study way back in 1975 which said we took the patients back. Patients who were anesthetized under plane 3 of surgical anesthesia with ether. They were taken back by hypnotism back to that state, and then they were able to recite whatever happened at that particular time. Okay, so whatever we are saying is unconsciousness and this and that under anesthesia, it's not that there is no impression on the mind. There is always an impression in the brain about, that's called the implicit memory. So when they took them back with hypnotism back to that particular state of anesthesia, go back, and then they are able to recollect the entire conversation that was going on in the theater during that time, though there is no conscious recall of that. So that is what is implicit unconscious memory that is there, and it has a lot of impact on the behavior of a person sometimes later. It can have, it's not it has, it can have, or it can influence your thinking or your behavior even after a few years of time. And that is what we should keep in mind. Now, the objective for this is to define the magnitude of the problem and its implications, and methods to detect the awareness, current practices to prevent awareness under anesthesia, and controversies regarding sequelae due to awareness under anesthesia. Okay, these are the 4 things that we are going to cover in this particular class. What's the magnitude of the problem? This has been analyzed. As I told you, around 2008, there were so many articles that have been published, so many things that is. So one of this is a meta-analysis, review article on that, and which analyzed the studies that have been done to bring about the level of awareness problem in under anesthesia. This was in 2011, I think. And what they found is that number of patients with definitive awareness, in number of patients here, the number of awareness is here, that's what it is, 1%, 0.13, 0.18, 0.72. So it ranges from 0.13 to 1% of cases of the study, and then the studies. It is not that the percentage is the same. It could be much higher because it is not documented, it is not published, it is not coming out. That's what it is. And this is from the published studies. That's the magnitude. And possible awareness, if you look at this, there are 2 things, definitive awareness, and this is possible awareness. The percentage goes up still further. Here you find this is 9.82%. The possible awareness. What do you mean by this possible awareness? What do you mean by this actual awareness? We'll come to that a little later. Okay, now the perception of awareness. What do you perceive when you say what is that perception that you have to say that there is awareness? Is there is sounds of conversation, there is sensation of paralysis, anxiety and panic, helplessness and powerlessness. These are the common things that the patient express when you post-operatively, when you interview them. And least common are the visual perceptions, that is dreams and other things, intubation or tube in the throat, feeling of operation without pain. So these are the common perceptions of awareness. Well, let's go to why it is important. All of us anesthetize. Have you ever thought about what happens to the patient after they get out of anesthesia and go to the ward? I just want to make an impression on your mind. There is something that we do. Anything that we do has always got action and reaction. If you take it in that. So there is nothing that's absolutely safe. You do this, it is absolutely safe, and then everything is fine. So whatever we do, there is a reaction to that. The body reacts. So sometimes you don't realize it. Sometimes you do realize it. So the distress it produces during the episode, that is one of the perceptions of the patient who has and doubts about whether what they experience really happened or it is a disordered mind. That's what patients start thinking. Is it really happening, or is it that I'm just thinking of this? What is this? So that kind of a disturbance. And then the last one is the post-traumatic stress disorder. These are the graded things. The last one is this. This is what post-traumatic stress disorder. I'll tell you some cases. 25-year-old multi posted for PS in the evening as an emergency, because that is the time in 1974, first year resident, myself. Okay, but I didn't do the anesthesia. Okay. Anesthesia, I mean, we our colleagues, we just came down, let's go for the coffee. Then she said, no, I have a case, I'll just finish it and come, just wait. So we were waiting outside. The case is 15 minutes procedure, thioscolin, intubation, nitrous oxide, oxygen, intermittent scolin. Tubectomy was done in 15 minutes. Patient is extubated. And then to have a patient who is very violent, trying to jump off the table, abusing everyone and screaming. That is what the patient immediately after extubation. They thought, no, something, so sedated the patient and brought the patient out. Patient will not get sedated. In spite of giving 50 milligrams of pethidine intravenously and 10 milligrams of diazepam, patient will not go to sleep but still remaining agitated. So just calm the patient down and send back to the ward, not thinking, okay, everything will be fine. But it did not stop at that level. Anytime she is, when she is conscious, she is abusing everybody and then quite irritable. So if you sedate her, she becomes much more and more agitated. That is what was happening. So after a day, we said stop and then put the diagnosis postpartum psychosis. That is what the diagnosis that was put for the patient. But after 3 days, when we went and inquired, had an interview with the patient, finally she came out saying that, I do not know, but I get very bad dreams if I go to sleep, and I have a lot of pain. Nothing is happening at the time. Just 15 minutes procedure that was done, very simple, 1-inch incision, put a finger inside, loop the tube out and ligate it and put it inside. That's all happened. But you think there's not much of pain, not much of thing, but this is what happened to that patient. And she had to diagnosis postpartum psychosis, then she was given 3 months leave and then sent off. Then she came back, she said, no, I am not able to sleep in the night. Anytime I go to sleep, I get the dreams. I had very, very bad dreams and I am not able to. So she was off the work for about a year. Because I know about this patient because she was a staff nurse in Japan. So finally it took her at least about 3 years to get back into the normal life of whatever she has to do, and then she came back for work and continued to work. That is what. So that is one case. Yeah, case number 2. 30-year-old lady, emergency LSES, general anesthesia, gas oxygen relaxant. After recovery, the patient quietly asked, "What the hell you fellows are doing?" The same conversation. She is a doctor. She said, "What the hell you fellows are doing?" I could hear every bit of conversation. Luckily, she was not agitated. She was not upset. She was, but this definitely had an impact later in life for some time before she could come over this particular experience of awareness, where she could hear there is no pain, there is no other thing, but she could hear every bit of conversation that went on in the theater, and she could recite it. You fellows were telling this, you were telling this. Yeah? And it upset me when you said the baby is not crying. Okay. Now, case number 3. 90 kg, 30-year-old man, emergency lab got me for severe melena. Hemoglobin was 4 grams, BP was 80-50. After the induction, initially maintained with gas oxygen and halothane. And the halothane was cut off after 30 minutes because of unstable hemodynamics. The procedure lasted for about 4 hours. Then resident cut off the nitrous oxide, also after giving some morphine, thinking that oxygen delivery is not satisfactory. And so he cut off the nitrous oxide and thought, whatever I am giving is enough with this particular hemodynamics, because BP is all the time around 70 in the patient. And then they could not find the place bleeding. They explored everything. They found, absolutely they can't identify where it is bleeding from. Then abdomen was closed and the patient was put on ventilator. He was resuscitated for 24 hours. After stabilization, he was extubated. Okay, that is what the story. What happened? 2 days later, the patient had another severe bout of melena. And the senior surgeon wanted to explore. The patient refused to give consent. I said, I will die. I don't mind. I will die. I will not go back into the theater. That is what is the exact words of the patient. Let me die like this itself. I don't care. But I do not want to get back into the theater. Then because and lot of convincing, and finally what to explore elaborate integration said total awareness with pain during previous episode and couldn't express anything for 2 days because he was on ventilator. I mean, he did not know whether the surgery is over. Because next to one day he was on a ventilator, he was paralyzed, and then there's a tube inside. He could not express, but he had felt a pain. He continued to feel that pain, and that's what it is. So it took a lot of persuasion for me to promise and make him agree for the second surgery, because if you don't do that, he is going to die. He said, so after a lot of convincing, after 2 days he gave consent, and then we had to take him back and maintain that time, because didn't want to use a halothane, second exposure within 2 days, all those concerns. So we used a technique in which we gave an inhalational anesthetic continuously, that is trichloroethylene through the open circuit, vein circuit, and then continued with anesthesia, making sure that he is not conscious, because made him unconscious and not reacting to pain before we gave a relaxant, before we started surgery. And so all that we have to do that, and to remove the phobia and to prevent post-traumatic stress disorder. I do not have a follow-up of this patient after 10 days, so I cannot say whether he developed this or he did not develop. But definitely this was the episode that was quite disturbing. Okay, so this is what it is. What is post-traumatic stress disorder? Intense fear and helplessness and horror. That is what this is the symptom that are likely to be there. Recurrent and intrusive recollection of traumatic event, including images, thoughts, perception, and dreams. That versus, see, this is not only after anesthesia. Even if you have an accident, somebody has an accident, you have seen that accident. Okay, right in front of your eyes, you see that person having an accident, the person dying. That also can produce a trauma in your mind for a long period of time. For you to get over that might take a long time. And that is also a part of that post-traumatic stress disorder. And persistent avoidance of thoughts, feelings, conversations, or activities associated with the event. That's precisely what it was with that first patient that I told you. She didn't even want to talk about it, but because the very thought of that produced pain, even though without any. And persistent symptoms of increased arousal. You don't sleep, you just get up from the sleep saying, suddenly this is what it is. Difficulty in falling asleep, inability or outburst of anger, difficulty concentrating, hypervigilance, exaggerated startled response. Duration of the disturbance is more than 1 month. It might prolong for a much longer time. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So all this. So finally, this becomes a psychiatric disorder which needs a treatment for a long period of time to get over what is happening. So these are the things that are possible. And that is what is termed as post-traumatic stress disorder. Have any of you experienced this? I'm not talking about anesthesia, but otherwise. It could be anything, yeah?
Tsunami, after seeing those images of the tsunami, I had some dreams like I'm in water, but there's nobody to help. So that.
How long did it last?
For
A few days. Okay, that it has not gone into a disorder yet. It is only a disturbance that has happened. Okay, let's look at the methods to detect awareness. One is isolated forearm technique. Other one is postoperative structured questionnaire. What is this isolated forearm technique? Does anyone have an idea about what is this? Abbreviation, if you put as IFT, normally you will think about interferential therapy. Okay, so IFT in anesthesia means isolated forearm technique. What do you do in this? You isolate the arm. You put a tourniquet and isolate the arm before giving the relaxant. Okay, patient is anesthetized, pepper, and tourniquet is applied. After that, only the relaxant is applied. And then you look at the response of that particular hand for when whatever is happening, for a voice command, for an incision, or whatever it is. So, and because this is not affected by the relaxant, the patient will be able to articulate this particular hand. So if you say just move your hand, the patient might move the hand. Or if when they make the incision, there could be a purposeful movement of the hand. When the patient is totally paralyzed, all this cannot happen. So this is what Hager he did when he wanted to in 1970 or 1980. They said muscle relaxant reduces the MAC. And so he did the study to say that whether it is actually happening or it is muscle relaxant, does it, because of paralysis, the patient is not reacting. So he used this technique, isolated forearm technique, to identify and say that muscle relaxants, yes, to some extent they reduce the MAC. And that's what. And that is a technique, one of the technique that is used for detecting awareness. Another one is postoperative structured questionnaire based on interview. So this is intraoperative and this is postoperative. So better to prevent rather than treat it. So, but how frequently this technique is being used to identify awareness, it is not much. Because people don't think on these lines of patient having awareness. And so that is... Now, also the interpretations of responses using isolated forearm technique. This is published in 2015 under general anesthesia. Who is this man, Pandit? You have any idea? He's an Indian. He is a Sardaji who has gone from Chandigarh to this place, Nuffield Department of Anesthetics in Oxford, and he was the professor there. He is still, I don't know. He is older than me, so maybe he's not there now. So this is a review article on interpretation of the responses to isolated forearm technique, and what they interpreted: IFT response, spontaneous movement detected, directed to stimulus indicating awareness. That is, when you make an incision, hand automatically comes like this. Have you people noticed it sometime when you thought that this patient is adequately towards, and then you go and give something more, or you paralyze and stop that? One of the things you do. So what exactly you'll have to do? You'll have to decipher what I should do now, not just give a relaxant. Okay, here it is after isolating, the movement has been established, and that is the awake state, and sedated, response directed only to the command, and then spontaneous movement only without any correlation to whatever is happening, and no response here when there is a deep anesthesia. So this is the estimated anesthetic concentration. And this color indicates the progression from conscious state to no response state. That is what finally they put it up. So interpretation of the isolated forearm technique also needs a little bit more of refining to say that the patient is having a recall or not having a recall. And then this study that came out in 2013. Assessment of intraoperative awareness with explicit recall, a comparison of two methods which compared IFT and then not IFT, compared questionnaire, two types of questionnaire to identify what happened and to identify the awareness. And one of the method is modified Bryce interview. This is a very simple one where you have 5 questions. These 5 questions to be asked to the patient, one immediately after and then one after few days. Actually, this particular study was asking these questions at 28 days post anesthetic. And this Bryce questionnaire, this was introduced in 1970. It was published in 1970, but People started using it only after 1990 and 2000 for identifying postoperative, intraoperative awareness. And this was compared with the quality assurance methods of questioning within 24 hours of awareness. And that is, so what did they find? They find that Bryce's questionnaire could identify 19 people, whereas this particular questionnaire could identify only 3 people. And the incidence of awareness was, the percentage you calculate will be 0.18%, whatever it will. So Bryce questionnaire postoperatively is ideally able to identify more number of patients who had awareness during anesthesia, but maybe without any consequences. Okay, let's go on to prevention of awareness under anesthesia. How do you prevent? I think it's missing. One is identification of high-risk patients. Why do you call them a high-risk patient? These are patients who may need intraoperative depth of anesthesia monitoring to balance anesthesia, balance amnesia and unconsciousness, with the need to administer a less anesthetic agent as implicated by the clinical condition. Who are these group of patients? One is very highly educated doctors. The first thing, because they know a lot of things, and they will resist becoming unconscious, and that is what it is. So you will have to monitor. And who are the other group of patients who react to this, who are likely to have this kind of a thing? Can you make any guesses? Substance abuse, okay. I can't follow. Type A personality. What does it mean? Generally anxious. Okay. Then anything else? Cesarean sections, yeah. Then? History of previous awareness. Okay, I've given you 3 cases, yeah. Yeah. Then? Cardiac surgeries. Okay. Hemodynamically unstable patients. Okay. So, hemodynamically unstable patients, that's what the history I showed you. And obstetric patients undergoing cesarean section, and patients undergoing cardiac surgeries, because in between you just stop everything and put them on bypass and think that everything is fine. Patient is not going to feel anything. You think that taking the temperature down to around 28 degrees, everything will be abolished. That is one. Morbidly obese patients, because you don't know how much you are giving, what is going to be the effect. And difficult airway patients, before putting the tube, you don't want to give much, and then sometimes you have the patient, you think you have anesthetized, but the patient is conscious. That is patients receiving total intravenous anesthesia. That is another high group of patients who are likely to have this. Okay, use of preoperative benzodiazepines. It's an anxiolytic and amnesic effect mediated via the GABA receptors, and they may prevent consolidation of the intraoperative perception and its memory formation. See, that's what it is. It is not that they don't feel. I mean, they might have been conscious, but conversion of that particular experience into a memory and storing it may not happen. It might interrupt at that level. So implicit formation of memory may not be there. So recall will not be there. That is how this benzodiazepines act. What are the examples of benzodiazepines? Yeah. What are the drugs? Midazolam, diazepam. In between diazepam and midazolam, there are a lot of drugs, which are alprazolam, Lorazepam. Yeah. Something more? Clonazepam, okay. That group only. Nitrazepam, clonazepam, diazepam, all that. Okay, so one of those, if you use a pre-medication with for quite some time, lorazepam has been used as a pre-medicant, diazepam has been used as a pre-medicant, midazolam, it cannot be given orally, so it did not come inside in the pre-medication. And but there are a lot of controversies of giving and benzodiazepines to the patients because of postoperative cognitive dysfunction has been established as one of the factors, and so people have started using less and less of benzodiazepine. Though it is useful in interrupting this and then prevents the memory formation of whatever happened, postoperatively there's a cognitive dysfunction that has been established, so people are talking against using any of the benzodiazepines intraoperatively. Does it mean we should not have any if it is, why should you correlate it only to intraoperative period? Normally also you should not be administering if it leads to cognitive dysfunction. But they say no, it is only predominant when it is postoperative, given in the intraoperative period and postop. So I do not agree with that argument, but still that's a factor that is there, saying that post-op cognitive dysfunction is more. Okay, dose adjustment to balance between clinical effect and amnesia and the unwanted postoperative cognitive dysfunction is vital in solving this problem. That's a statement that has been made. So especially when you're using the benzodiazepines. Now, other preventive methods that you'll have to take is careful check of the anesthesia machine and special care to avoid incorrect drug administration. Okay, these are the two things. You might think that you are given thiopentone, you might have just injected some saline. I mean, I'm not joking. It does happen. It would have been loaded and then saying that I am going to take the thiopentone at the end. I am not going to dilute. You have taken 9 ml of saline and then you are going to take something more. Things like that do happen. So you would have taken 5 ml. I am going to add up 1 ml of morphine into that to make it 3 milligram per ml, and it would have been just left like that, and you will be giving only saline and thinking it is morphine. Okay, so special care is to be taken to avoid incorrect drug administration and careful check of anesthesia machine before you start. We will come back to that a little later. Then the restricted use of muscle relaxants. It's because we talked about it, it is neither a component of anesthesia nor an alternative to adequate anesthesia. I'm again emphasizing that it is to be used only as a surgical indication whenever it is needed, not as a component of anesthesia. It could also conceal or affect reliability of the EEG-based depth of anesthesia monitors. Okay, so that is another point, that use of muscle relaxant to be restricted to where it is indicated to produce muscle relaxant, not as an adjunct of anesthesia to facilitate you to be relaxed. Okay, monitoring depth of anesthesia. We talked about the depth of anesthesia that is needed for any surgery, for anything, what you should reach at. So what are the monitoring that is clinically? Traditional clinical signs are tachycardia, sweating, tear production, movement or grimacing, tachypnea, pupillary dilatation, and reactivity to light. How many of you have any time during the anesthesia checked for any of this? You checked? What did you check for? Tachycardia, because it's shown in the monitor, yeah. Okay. Then? Tear production. Any of you have seen under anesthesia? What did you think at the time? Why is the patient crying? Yeah, this you would have seen. Movement and grimacing you might have seen. Tachypnea, if the patient is breathing spontaneously, you might see that. Then how many of you have looked for this pupillary dilatation and reactivity to light? Nobody would have looked for that. These are the signs we totally relied on in those days when we had no monitors like this. We have to constantly monitor these things. So is there a central fixation of the eyeballs? Once you give a relaxant, then it is gone. Is there any tear production? Is there any movement? Any tachycardia and pupillary dilatation, which reacts to light. These are the monitors that things that we use to monitor the depth of anesthesia. But if the patient is breathing spontaneously, this is the indicator. Respiratory response to any stimulus. That gives you indication about the depth. Now you have all these techniques. You have the isolated forearm technique, which none of us have seen, none of us have used. Really? I have used, okay. Then other thing is lower esophageal contractions. It was studied quite some time in the 80s and 90s, because how do you monitor lower esophageal contractions? How can you monitor that? Lower esophageal contraction. Stop recording. Now, that is one thing that was used and then extensively tried to identify, but there is inconsistency in the performance of that, so that has been left out. But it has been tried as one of the methods to identify the light plane of anesthesia. Now, EEG-based derivative, that is, one is bispectral index, other one is entropy, third one is auditory evoked potential. What is bispectral index? All of you have heard these terms, BIS, entropy, and I don't know whether you have heard this, AEP, auditory evoked potential. Now, monitoring the exhaled anesthetic gases, that is what we extensively talked about, monitoring depth of anesthesia and what it should be and what level you should be taking it up to. So what should be the endpoint for that? More than 0.7 Mach. More than 0.7 Mach. What does it make sense to you? What she's telling? 0.7 Mach. Why 0.7 Mach? Minimum, it should be more than 0.7 Mach. Now, I am going to conclude with this particular slide. Again, it's going to be food for thought. Now, this article published in 2015, Intraoperative Awareness and Controversies and Non-Controversies. That is, they published this. This is a review article that is written about what are the controversies, what are the non-controversies that have been established till now about awareness. Okay, this is the diagram that has been put up. You find the two aspects. One is intended regional anesthesia sedation, other one is intended general anesthesia. These are the intentions when you start. Now, when it is intended general anesthesia, that's a whole lot. Then there is anesthesia awareness without recall. There is a proportion of those people that is there, awareness without recall, and then you have awareness with recall. What is this awareness without recall? There is no controversy on this. All these points are non-controversial. Incidence is much higher than awareness with recall. What is this awareness without recall? Last time I showed you one study where they used 1 Mach sevoflurane and they have intubated and showed that these patients moved, these patients during the intubation time, there was a rise in blood pressure, there was a rise in heart rate, everything. But finally, post-operatively, patient did not recollect any of that. That kind of a study, many number of studies are there to show that, yes, there is a response, there is an implicit memory that might be produced inside, but the explicit memory is not there, and so there is no recall of the event that went on. Okay, so that is quite a large number of patients might have this, and but it is not to say that you don't have to worry about it. You should take care that even that is not there. And then awareness with recall, it is prevented by using the EEG monitors like BIS and entropy, and detected with Bryce interview, quite a number of patients, And then in that very small number, distressing awareness typically with neuromuscular blocking agents. That's what. And post-traumatic symptoms, susceptible patients, that's a small number. So compared to that, this number is looking quite small. But why should we worry about this small number? Yes, we should worry about this because you are playing with the life of somebody. And even if, see, you might do thousands of anesthetics, but if you have one death on the table finally after 40 years, your entire 40 years life is coming to a zero. You know that. Whatever is the experience that you have gained, whatever it is, finally, one mistake in the entire 40 years life is exaggerated to the extent that it covers your entire 40 years of life. Especially now with that litigation and other things, whatever you have earned in that 40 years will all go for one case to somebody because something has happened. That is what it is. So that is why we should be worrying about this particular small segment of patients and to avoid it as far as possible. And that again, this is non-controversial. This also is non-controversial. Awareness with recall incident orders of magnitude is much lesser than awareness without recall. All these are non-controversial, but what is controversial? Still not yet established. Intended regional anesthesia with sedation, you convert it into unintended GA. Because you say that something is not working and this patient is having this, patient is having that. So I am going ahead and anesthetizing the patient. Whatever is the experience that the patient had consciously at that time before you start a GA might continue even after you give general anesthesia. So that is why you find, that's why you find awareness without recall incidence is much, much higher when you have converted a regional into a general anesthesia, and also expected awareness with recall also is high, and unexpected awareness with recall is smaller. But again, this is controversial. The whole thing is controversial, and people agree to this because enough evidence has not been produced to say this is what is happening. And then again, these are again still not fully established facts, and again remain controversial. Psychological sequelae, that small number, which is psychological sequelae, what happens to them afterwards is still controversial, and how long it lasts and what it is. And dysanesthesia, does it happen? Again, another controversial factor. Dreams and awareness, genetic component. If you go into the net and then look at awareness under anesthesia, you might see some videos where people describe about awareness under anesthesia. Some of them might relate it to genetic component. My grandfather had it, my mother had it, my father had it, I am having it, I had anesthesia. So that kind of narrations all you might see. If you go into the net and look at YouTube's asking for awareness with recall, you might see certain videos. Okay, it might be related to genetic component. And post-traumatic stress disorder symptoms in susceptible patients is, again, all these points remain still controversial in the sense what they have said it as enough evidence has not been produced to establish this is what happened. That is what it meant by this controversial. So we are coming to the end of this session. What we have talked about is this magnitude of the problem, methods to detect the awareness, current practices and controversy that are related to this. Okay, I will refer you to that particular article about review article. All of you should read that because a lot of explanations and references would have been given for you to understand what all things that we talked about in that one particular slide. So I am again leaving it to you for your reflection and then recollection.